So, hi everyone, and welcome. I'll start by acknowledging that the land that I work and meet on is the traditional territory of many nations, including the Mississaugas of the Credit, the Anishinaabe, the Chippewa, the Haudenosaunee, and the Wendat people, and is now home to many diverse nations, Inuit, and Métis people. I also acknowledge that Toronto is covered by Treaty 13 with the Mississaugas of the Credit, and will invite you to share your land acknowledgement in the chat if you wish. So I'd like to welcome you to our first CPCRN trainee learning session. Bonjour et bienvenue à la première session de notre série d'apprentissage. Aujourd'hui, cette session porte sur la science de la mise en œuvre dans la recherche en soins primaires. This new trainee learning series is designed specifically for trainees to enhance their knowledge and engagement in primary care research and is hosted by the Building Capacity Committee of the Canadian Primary Care Research Network. CPCRN's vision is to create a sustainable pan-Canadian learning health system supported by patient-oriented, practice-based research that improves primary care. And today's session is on implementation science in primary care research, and we'll go over what it is, why it's important, and common theories, models, and frameworks used in the field. We'll explore how implementation science has been applied in various Canadian examples, and hear 3 trainees share some of their work. But first, I'm delighted to introduce today's speaker, Dr. Noah Ivers. Noah is a family physician and scientist at Women's College Hospital and an associate professor at the University of Toronto. He also holds a Canada Research Chair in implementation of evidence-based practice. He has mentored so many trainees who do implementation science work, and it is such a privilege to have him join us today. Over to you, Noah.
Hi, everyone. Thanks for having me. Daphne, I've known you for many years, and I did not know how great you are at French. That's fantastic. And I apologize that this will be unilingual English only, because I suck at languages. I can barely speak in English. So I'm going to put up my slides, and I'm going to try to talk to you for a number of minutes, and then I hope that I can talk with you thereafter. Let me put it into the proper mode here. There we go. All right. So yeah, thank you for the introduction. I'm a family doc and I do implementation science research. I'm in clinic a couple days a week. I try to do research the other days of the week. That is when I'm not running my kids around to their various sporting events. Let's dive in to a whirlwind tour of implementation science. I think if we're going to talk about implementation science, the place to begin is by acknowledging that we have decades and decades of health services research, literally hundreds or thousands of studies showing that the care delivered to our patients is suboptimal, both in terms of technical quality of care and also in terms of the quote unquote softer stuff. And so, for those new to the healthcare system, it's kind of like a Wizard of Oz situation. When you realize that if you see one doctor with the same problem as you see another doctor for, you might get totally different advice. And that's the foundation from which we start thinking, oh, well, there's got to be a way to bring to bear various fields of evidence to try to make that better, to try to make healthcare evidence-based and reliably delivered. So just a little bit of evidence to support that Wizard of Oz sort of statement. There's this wonderful systematic review published now a while ago showing that indeed overuse and underuse of various tests in primary care is very, very common. Depending on the test, more common than for other tests. But as I said, if you present to a doctor with a potential thyroid problem, you might get some sequence of testing that is totally different than if you present with the same thyroid problem to another doctor. And in a nutshell, implementation science is about trying to understand and advance the methods for addressing that type of problem. The other sort of foundational piece that we should think about before we dive deeper is just a little bit of, level setting around what actually happens in primary care. What are the things that a family doc like me does? And there's lots of ways of thinking about that. I think one of the best sort of ways of thinking about what primary care is using the sort of definitions of good primary care laid out by Barbara Starfield, that primary care is about offering first contact access. It's about being comprehensive. So thinking about the wide range of clinical problems and symptoms, not just diseases, that a patient can present with and often presents with simultaneously. It's about being patient-centered as opposed to disease-centered. It's about continuity of care. That is to say, it is longitudinal. The care is for the patient over time, as opposed to just an episode of a particular condition. And it coordinates various aspects of health and social services that the patient may or may not need. So that's the Barbara Starfield model. You see that laid out on the one side of the screen. And in the middle of the screen, you see that, what can come through my door is literally anything. And that makes for a somewhat chaotic but super fun environment. It's not as chaotic as the emergency room, where things have various levels of triaging and sometimes as emergent as resuscitation. But it offers the far other end of the spectrum in terms of careful cognitive work that requires multiple visits over time. So if we're thinking about how to address the problems of overuse and underuse or misuse of testing or treatment, about the idea that evidence isn't as reliably implemented as we would hope, we can think back to the initial, pre-implementation science perspective on how to address this. And it was basically this linear process of, well, let's get some evidence, we'll put it into the guidelines, and that will no doubt lead to better practices and patient outcomes. And if that were true, everybody worldwide would follow the 10 Commandments, because those guidelines have been in place, forever. So of course, putting things down into a guideline doesn't work in and of itself. Guidelines do not self-implement. Which brings us to implementation science. And if I asked you to define implementation science, you'd have to use a whole bunch of words that are in that word cloud over there to get it right and to try to be comprehensive. And there are some implementation science definitions that we'll get to in a moment, but I will basically emphasize this picture on the other side of the screen, which is, implementation science recognizes that people and the context that they live and work in is a complex one. Good implementation science delves into that and works with it rather than denies it and sort of jumps off a cliff. So here's some actual definitions, because sometimes you need to write something specific down rather than the word jumble that I put up there for you. You can see the emphasis here. There's a lot of overlap on the study and advancement of methods to make practice better, basically. The study and advancement of how we go about improving quality or improving, putting better policies or practices in place. I would hope that many of you have seen this. If you have some introduction before to implementation science, this is the super dumbed down version, which I personally love. It centers the evidence-based thing that you'd like to see more reliably implemented, and it calls that the thing. Traditional clinical effectiveness research tests whether that thing works. Once you know that that thing is the desirable thing to do, that it works, implementation research tries to help us do the thing more reliably. And within implementation research, we may use different implementation strategies to try to make people or places do the thing. And we would measure implementation outcomes to understand how well we got people to do the thing. So that's sort of implementation science in a nutshell, using super simple language. But if we're going to talk about what a person like me who does implementation science spends their time doing, a lot of it's around knowledge synthesis, trying to collate sort of knowledge from various literatures, or perhaps a series of randomized trials in some cases around how well different implementation strategies might work, or in a more nuanced kind of question, what works well for whom in what sort of circumstances. And more excitingly, in my mind at least, we spend a lot of time trying to apply or ideally advance methods to understand why things aren't happening as we would hope right now, and addressing the answers to why they're not happening as we would hope right now. And we hope that in unpacking the answers to those questions, we can pursue spread, scale, and sustainability of best practices, so that in an ideal world, the outputs of the implementation scientists lead to exponential impact in terms of better patient care, better patient outcomes, better policies or practices that affect, ideally, entire populations. That's the goal. That's why we do science. For me, I'll just add, if I just, nothing wrong with just being a family doc, but if I was just a clinician, just doing family medicine, perhaps I could look after 2,000 patients if I worked really, really hard. If I do my research really, really well, perhaps I can support evidence that can lead to benefit for millions of patients. That's the dream, at least. So if you're going to do implementation science, I would propose to you that there are 4 key questions to ask that can guide your work. Question 1 is, who needs to do what differently? Question 2 is, why aren't they doing those things reliably already? Question 3 is, what can we do about it? And question 4 is, how can we evaluate it? So we're going to dive briefly into each of those things to give you an introduction to the relevant implementation science frameworks for answering each of these given questions. I will just add that this 4-question framework was developed by my friend Simon French, who is in Australia. So if you're going to answer the first question, who needs to do what differently? The implementation science framework that's quite useful for that was published by a friend of mine called Justin, who's in Ottawa, Justin Perceau. And he asks us to basically describe this in excruciating detail. Yeah, we don't just want to sort of stay at a high level. We want to get into the weeds here about all the different people that might play a role in getting us to, for instance, prescribe blood pressure medication better, or do that thyroid test at the right time for the right person, etc. And you can see that he lays out the desirable thing would be to define the action, actor, context, target, and time. You can take a screenshot if you want and Google that paper. So if you can define in excruciating detail what it is that you're hoping would happen in an ideal situation, the next question obviously to ask is, why aren't they doing that already? What are the things that are getting in the way? And there are some typical ways that we try to answer that question. We often blame culture. And it's true that culture is super important. There's an old phrase that culture eats strategy for breakfast. But saying that the culture is no good or the culture is good or whatever, it doesn't feel very actionable. I propose that what we need is something that in implementation science we call a program theory. That's kind of like a very detailed logic model that helps us move from what is happening right now to what is getting in the way of what we want to happen and how we can overcome those things. And so if we use a particular example, a lot of my own research is in the realm of what we call audit and feedback. That is measuring quality of care and giving those quality metrics back to clinicians to let them know how they're doing in hopes of spurring specific improvement. We have this really cool theory called the clinical performance feedback intervention theory. It's kind of complicated. I won't get into it this moment. You'll have to bring me back if you want to learn more about it. But basically, it lays out all the various factors that one might think about if we give, for instance, physicians some detail about their antibiotic prescribing and they continue to overprescribe antibiotics. We did that in one study recently here in Ontario, and we tried to apply that theory to make sense of why it did or didn't work for certain physicians. And that can be really, really helpful approach when you come at it already from a theoretical lens. But if you don't have a specific theory for a particular strategy or a particular context, there's this thing called the theoretical domains framework that helps us more broadly understand what are the different things that can contribute to a person's behavior or potential behavior change. And the folks that developed this theoretical domains framework basically collated 100 years of behavioral science and behavioral theory into one sort of pretty comprehensive framework that helps us make sense of how do we change a patient or clinician's behavior? What are the things we have to think about? What are the things that could be getting in their way? If you haven't had a look at this book that's here on the slide, I'd encourage you to. It's a great overview of sort of a behavioral approach to implementation science. If you recall, the next question was something about once we know what are the things that might be getting in the way, why aren't people doing what we hope they would be doing already? Then our next question is, well, what can we do about that? What are the feasible intervention or intervention components or strategies that we might put into place to overcome those specific barriers or facilitators that we have tried to identify as being a problem for the relevant actors, who aren't currently doing what we would hope them to be doing. So for instance, that family doc that's still prescribing way more antibiotics than he should. What you see on the screen is an example of building out a detailed program theory that maps from all the things we can get in this case, a patient navigator to do, to the barriers and facilitators that the patient that they're helping to navigate might be having as a means of heading towards specific patient behaviors that can lead to specific desired patient outcomes. I would argue that if we're going to try to make things better in healthcare, this is the kind of level of detail that we need to get to. This is the level of detail we need to get to if we want to advance better implementation science around how we do quality improvement more effectively. Now, fortunately, there's some online tools that can help with this. That's the goal of this slide. Again, using a behavioral approach, there's a website there at the bottom. You can actually take those theoretical domains framework sort of bearers and facilitators that you identified and map them to specific elemental behavior change techniques that you might incorporate into your intervention strategy, your implementation approach that tries to make things better. This is all about trying to be more systematic in the way that we try to improve things. Too often, what we see is people jumping ahead to the quality improvement approach without doing these preliminary steps. And the result of that is sort of doing that kind of approach is unsystematic and therefore unscientific, and it's very hard to learn from whatever effects we find. So let's say the quality improvement approach that you took worked. That's fantastic for your local setting. You've made things better. I'm so happy. But how can the next clinic learn from that if we don't know exactly what you did or exactly why you did it? One of the things that we recognize, as I laid out earlier in implementation science, is that context is super, super, super important. And one of the frameworks that helps us think through the various aspects of context is this thing called the Consolidated Framework for Implementation Research. This is an image from their version 2.0. And you can see the website there if you like. What I want to emphasize is, earlier I sort of talked about how people will often attribute change or lack thereof to culture. And in fact, we find the word culture in here when we look into the inner setting. So that's like the clinic or the hospital ward or whatever, where you want to make a change. But in this instance, the word culture comes with a specific definition and some ideas about how we might understand it and address it. And it also comes in alongside other things we might consider as worthwhile to assess, measure, or address if we want to make a change. What's more is it encourages us to think about the outer setting. So any given hospital ward or clinic where we want to make a change exists within a broader sort of society, where things may or may not be a priority. So right now, for instance, we have really crummy access to primary care, and primary care is totally burnt out. And so that's a factor in the outer setting. It relates to immigration policy and funding and all sorts of things that are above my pay grade. And that has this impact on the inner setting, a given primary care clinic, where you might be trying to make a change. And I think failing to recognize that can really, really limit us. The good thing about frameworks like these is it reminds us to take into account all these different categories of things that may or may not be a factor, but at least it prompts us to think about them before we go down the road of trying to make a change that doesn't stand a chance of happening for whatever reason. And as I've just alluded to, context is super important, especially in primary care. This is a picture of one of my favorite online characters. This is, the way most family docs spend their day, feeling a little bit overwhelmed and sort of desperate for help. And many of you will be familiar with the idea that it's the administrative work that's a major contributor to burnout right now in primary care. And so, this is really, really crucial to recognize, because a lot of things that are happening out there in the sort of quality improvement world one way or the other, they relate to asking the family doc to do just one more thing. But if you have dozens or hundreds of folks asking you for just one more thing, it's a problem. Okay, circling back to those 4 questions, knowing that my time is limited, I wanted to highlight that there's also a great framework for how you'll know it's working. Whatever your implementation approach was to try to make things better, there is this set of what we call implementation outcomes or metrics that you might choose to measure. You might choose to measure some or all of them. This is from an amazing professor called Anola Proctor, who's down in the States. And you see the definitions there. Again, you can take a screenshot. I don't need to read it for you. But the point being, these are not outcomes specifically related to patient care or outcome. These are outcomes around your implementation intervention. What I like doing is randomized trials of implementation strategies. And that becomes a relevant thing when you've already done the preliminary work of, remember that slide where I talked about the thing? You already know the thing is a good thing to do. You've already done the effectiveness trial. You already know that the thing is not reliably implemented, as is the case with so much health services research. It helps us find that. And you already have some idea, but not a perfect idea of what works to help make that thing more reliably implemented. And so that's when it's time to implement a randomized trial. I shouldn't have used the word implement there again. That's confusing. That's the time when it's time to conduct a randomized trial of an implementation strategy. And there's a guide for that, which is on this slide. And so if you take a screenshot of that or just Google it, if you're interested in running a randomized trial of implementation strategies, yeah, there's not an app for that. We didn't have the money, but there is a guide. Now, one of the things we highlight is that anytime you do an implementation trial, what we really need to advance our knowledge of why it worked, not just whether it worked, is an embedded process evaluation. We are definitely interested in whether an implementation strategy worked, but arguably, we're even more interested in the world of implementation science in why and how it worked. And those are classically qualitative questions. They can be assessed quantitatively as well, but most often this is about embedding qualitative work within the randomized trial to understand some of the issues that we lay out here in terms of fidelity and mechanism of impact. These are really, really crucial to understand if we're going to spread and scale whatever our intervention was into a new context. And I would argue what we really need next is we need this group that's here to help us build primary care implementation science laboratories. I'm almost done, I promise. What is an implementation science laboratory? It's kind of like a learning health system where the focus is not necessarily on effectiveness studies, but is on implementation science. So understanding and advancing how we more reliably implement things that we already know work in the primary care setting. And systematically learning from that, and then spreading and scaling what we learn. And so, this doesn't exist yet. There's no such thing as a primary care implementation science laboratory. There are implementation science laboratories that we've stood up that examine particular topics. For instance, in Australia, there's an implementation science laboratory that focuses on improving the quality of nutrition in schools. And they're testing different implementation strategies, working with public health to improve the nutrition of children. Amazing. We have in Ontario an implementation science laboratory that's all about advancing how we understand a particular implementation strategy. Audit and feedback can work in different settings for different topics and so on. But this is a different thing that I'm proposing, and I'm handing off to any and all of you to stand up. We need to know how to help primary care more effectively achieve its goals. That is, providing access, continuity, comprehensiveness, those things we talked about upfront, coordination, patient-centeredness, and to do it more efficiently. This is the challenge of our time. It is what Jane Philpott will be working on. And if we're going to do it well, implementation science will have a role to play. And before I finish, one more point. And that is to add that I think implementation science is crucial for equity, which I know many of you care about. And if you don't, then shame on you. Let me just explain this curve a little bit. What you see with the gray curve there, the bell curve that's gray, is you can imagine each of those bars underneath the gray curve is a primary care practice. And the average performance of the primary care practice, or the average primary care practices, are there in the middle of the gray curve. And there's some practices that are far end of the curve. They're gray towards the right of your screen. And there's some with more room for improvement, the blue bars. In an ideal world, our implementation interventions would shift the entire curve over so that everybody, no matter what practice they're in, is getting better care. But also it would narrow the curve so that especially those that were getting care in a practice that had the most room for improvement, they were the ones that got the supports needed to push their care even further in a desirable way. So some take-home points. If you're going to do implementation science, there are 4 questions you want to ask and answer. I've urged you to try to use frameworks for each of these things because it'll help you be more systematic and comprehensive. This slide is a sort of reminder of some of the things that I've already said, but I won't belabor them. And I'll encourage questions, and I'm happy to talk, but I think there's some follow-up presentations first. That was cool.
Thank you. So now we'll switch over to the trainees, sharing 3 slides in 3 minutes for some of their work. So we'll start with Andréane.
So hi, everyone. I hope you see my slides. Yes? Okay, good. So here's my doctoral research on optimizing the role of nurses in primary care for chronic pain management. So just quickly, chronic pain is a persistent pain that lasts for more than 3 months, and it affects over 25% of the population in Canada. And it's also leading to important biopsychosocial consequences, including reduced quality of life, as well as impairments in physical health, mental health, and social functioning. So despite their expertise in managing chronic conditions, nurses in primary care remain underutilized in the management of chronic pain. So this is why my doctoral research aims to address this gap by using an implementation science approach. So in my research, we are using the Graham's Knowledge to Action framework, which is facilitated the translation of evidence into practice. So this framework is important to understand that is more like a process model that clarifies a set of 7 steps that we have to go through to help the implementation process. So in my research, we are just focused on the first 2 phases following an explanatory sequential design. So the first step is adapt the knowledge to the local context. So we used a Delphi method to identify key activities that nurse could do in chronic pain management, and based on input from nurses themselves and patients living with chronic pain. After that, in step 2, we assess the barrier and the facilitator to the knowledge use, and we use a focus group to explore some barriers like related to scope of practice, collaboration, or an organizational constraint. At the end, because it's a mixed method, we integrate findings from qualitative and quantitative data, and we are now developing target strategy to enhance implementation of a nurse in chronic pain management. Additionally, just to let you know, we also incorporate the Ivers framework, which is more like a determinant framework to help us to assess barrier and facilitator. And in the integration of the mixed method, we also use the Rogers diffusion of innovation theory to help us to develop some strategies. So by combining these 3 frameworks, we aim to develop sustainable strategy for integrating nurse into chronic pain management, and we hope so somewhere contributing to improve care for patients living with chronic pain.
Thank you, Antoine. Our next trainee is Fikadu.
Hello, everyone. I'm Fikadu Yohalashet, PhD student at Queen's University. Under Dr. Katin Donley's supervision, I conducted a feasibility diabetes self-management coaching program in the primary care. So today I'll talk about intervention adaptation, which could be a precursor for the implementation of an evidence-based practice. So intervention adaptation is a tailoring of an evidence-based program or intervention to a new context, and it have a lot of relevances. It improves population health by bringing effective interventions from other contexts, and it protected the public from intervention-related harms. And it's also crucial to replicate the effect in a specific context or population. And it outweighs developing a new intervention, like it saves resource, and it ensures sustainability of a program effectiveness. So intervention adaptation have various extents. So people can conduct a simple language alterations or changing the core intervention components. So we can conduct altering the setting or changing the setting, like from the hospital setting to the primary care setting or to the community-based setting. Or the adaptation can be changing the target population or the audience, like if the primary evidence-based intervention was conducted among type 2 diabetes patients, we can modify this into type 1 or from one disease condition to the other. Or the adaptation can be changing the mode of delivery or the technique of implementation of the effective intervention, or it can be changing the culture or the language, or sometimes we may conduct modifying the core intervention component. So intervention adaptation is just varied, but broadly they can be considered as changing the context, changing the culture, and changing the content of an intervention. So for the diabetes self-management coaching, we follow an ADAPT guideline or ADAPT guidance, which are 4 steps. And it's developed by Grammar, who is one of the biggest contributors in the implementation science. So the first we do is we assess the rationale for intervention adaptation. We primarily conducted systematic review on the diabetes self-management practice in the Ethiopian context. Then we just identified an evidence-based intervention which can be fit with the context. So to do that, we just make some review of the evidence-based practice in relation to diabetes coaching. Then the next step is plan for and undertake adaptation. So here we conduct like gathering expert groups who can conduct the adaptation and communicate with the original intervention developers, and getting permission to conduct adaptation was another important step. Then we facilitated 3-round panel discussion of experts, and through that we changed the adaptation, or we modified the adaptation into the local context. So the next step was conducting a feasibility trial. We conducted a pilot randomized control trial among 40 participants. And finally, we assessed the feasibility, acceptability, and the preliminary effectiveness of the diabetes self-management coaching. And the last step is implementing and maintaining the adapted intervention, but this step was not conducted because it's another phase. So it's all about, I will be happy to entertain the questions. Thank you.
Thank you. And I'm the next trainee. So, hi everyone. I'm Daphne, and I'm a PhD student at the University of Toronto and a trainee at Women's College Hospital. And in my work, I'm using implementation science methods to develop an intervention to support community pharmacists in Ontario in delivering minor ailment services. So in January of 2023, the scope of practice for pharmacists in the province expanded, allowing them to deliver minor ailment services, and that includes prescribing certain medications. Some ongoing evaluation work has shown that community pharmacists are motivated to work to their full scope, but they need and want additional supports. And so to develop this intervention, I'm drawing on a 4-step systematic method for developing interventions to change clinical practice that Noah talked about in his presentation. And so these 4 steps, again, are 1, understanding who needs to do what differently; 2, using a theoretical framework, understanding the barriers and enablers that need to be addressed; and 3, identifying intervention components that can be used to overcome those barriers and enhance the enablers; and then lastly, 4, thinking about how to measure behavior change. And so to do this, I'm using a sequential mixed methods approach. From some of the health administrative data, we've learned that urinary tract infections and conjunctivitis make up almost 60% of all minor ailment claims. And so it's important to understand why that might be the case. We also learned that when we stratified pharmacies based on their claim volumes, those with higher volumes were often pharmacies that were located in urban areas, corporately owned, employed more pharmacists and pharmacy technicians, had more early career pharmacists, more female pharmacists, and were located in areas with higher neighborhood income quintiles. And so to explore why some of these differences are occurring and find ways to have better uptake and delivery of these services, I'm conducting a semi-structured interviews with pharmacists. And these will be guided by the theoretical domains framework, which is a determinant framework grounded in psychological theories that are related to behavior change, including 14 domains that are listed on the slide and reflect influences on behavior related to capability, opportunity, and motivation. So to select the intervention strategies, the relevant TDF domains will then be mapped through a validated tool to behavior change techniques, and these are considered the active ingredients of an intervention. And then we'll conduct a modified Delphi to achieve consensus on the intervention strategies that would be considered appropriate through consideration of acceptability, practicability, effectiveness, affordability, spillover effect or unintended consequences, and equity. And lastly, a logic model will be used to describe how the intervention is expected to work, and this will inform future evaluation of this intervention. That's all I have.
Excellent, beautiful slides.
So let's move on to, I guess, our next component. So if there are any questions in the chat, or if anybody has any questions, feel free to raise your hand and you can join the conversation. To get us started, I think some of the trainees do have some questions related to their work or some of the challenges that they're experiencing with some of their work. So wondering if any of the trainees would like to go first. Okay, I'll go. So I guess, Noah, we've talked a lot about different theories, models, and frameworks. And I guess for a lot of the trainees and people getting into implementation science, the question is always, how do we choose which framework to use? And then even when we have chosen our framework, for example, for myself, for the theoretical domains framework, there are so many domains. So when we're thinking about using it to guide our interviews, it's almost impossible to ask something related to everything. And then when we don't ask it, we risk not getting some of that information. So how do we kind of balance that?
When I see a patient in clinic, and we have to do like a full assessment, like maybe they have like maybe I don't know, they fainted. And if you think about the many things that can cause somebody to faint, it can be difficult to cover all of that in a 15-minute appointment. Not to mention that at that same appointment, maybe they are overdue for a vaccine or a this or a that or the other. Yeah. Oh, and their daughter is worried about this and their mother is worried about that and so on. It's literally like you have to prioritize. Perhaps my sort of feeling used to that as a family doc makes me feel a little bit easygoing about needing to prioritize things in the world of research as well. You're right that, when we want to be comprehensive, that goal is at odds with the desire to actually have a few actionable things to work on. Yeah. There's not an easy answer to that, how to balance those two things. If you miss something that was really important, it is totally probable that your intervention will be incomplete and, it may not work as a result. I think the hope is that unlike, so in clinic, I deal with that by bringing the patient back. And in research, we deal with that by interviewing or assessing, you're getting more data in some other way. Yeah, same idea. So interviewing more people, if it's just a single case study, getting different sources of document review, observation, whatever, and hoping that through that, like in any given interview, we may not have a full comprehensive thing, but across the set of the data that we're collecting, we hope we will. Or at least we can convince ourselves that we're not missing something super important. That's a bit of a cop-out answer, I know, but it's like you've asked an impossible question. Like, how can we be sure? Like, well, we get as sure as we can be.
Impossible question indeed. I hope it doesn't show up in my thesis defense. What about the part about choosing frameworks?
Oh, yeah. Sorry. Yes. So what I loved actually with the first presentation, how do I say your name properly? And Andrienne, was that? Okay. I'm sorry if I made it wrong. So you presented totally different framework, completely different set of frameworks than what I introduced the group to. And they seem to be very well, like thoughtfully chosen and appropriate. There is not one path forward here. And we probably have too many theories and frameworks. And I really, don't love the ongoing work to produce more of those. We have enough probably. Different ones have different strengths, I think. And, typically I teach that as I did in the very brief talk, which could have been 3 hours, but was 3 minutes, that CFER is very good for context and TDF is very good for individual behavior change understanding. And for mapping to intervention components. But I think the choice of the theory and the framework should depend on how you have framed the research question and which theory and framework can help you best answer it. I'm a pragmatist, so that's my answer to that. And there is some interesting questions in the chat. Could I go ahead and answer those? Would that be okay? So how we engage patient partners. This is such a cool question, actually. So we've worked pretty hard at that. For interventions that are about changing the things that clinicians do, it can be a little bit difficult to bring patients up to speed on the various things that, are the foundation for, before you even get into an implementation science project. You have to bring them up to speed on that Wizard of Oz problem. And that is something they're not all aware of, that actually, their doc might do the wrong thing for them sometimes. You have to help them come to grips with that as a precursor to even getting into the project, because that's our starting point. Our starting point is that things are going wrong and we need to fix them. But we do engage patients in that. We just know that it takes some prep work, and you have to account for the time related to that and so on. For projects that are about understanding and engaging, patients directly in changing their behaviors, like understanding, for instance, how do we get patients to go to cardiac rehab after a heart attack? Or how do we get them to take their medications more reliably or whatever? I mean, engaging with patients through the process of that is super high value. And I would encourage it. I'm not sure if that's specific enough. Rachel, did you want to ask a follow-up?
No, and so new level that answers the depth of the question that I have right now.
Okay, no worries. I'm an email away if there's something more I can do. Improvement science and implementation science, I guess it depends on who you're asking. I personally don't get very hung up on the semantics. I think that the difference is, depending on who you talk to, quite minimal. And it's about, I'm more interested in what are the types of questions we're asking and what are the methods we're going about answering them than whether we call it implementation science or improvement science or some other thing. I think it's worth, though, answering what's the difference between implementation practice and implementation research, just as part of that answer. And so implementation practice, or doing quality improvement work, if you like, is about taking what we've learned from health services research or implementation science research or whatever, and trying to actually do the work, trying to make things better in your local context, which is super duper important. And ideally, we recognize that the choices we make about how to try to make healthcare better should be just as evidence informed as the choices we make as a clinician about whether to prescribe this or test that or whatever. So that's what I would say about that. And so the implementation science is about advancing the methods and advancing the science. The implementation practice is about doing the work to make things better. Sometimes it's like a Venn diagram, though. Sometimes we do both at once. I don't understand the field of strategy implementation development question. Do you want to try to clarify your question?
It's just because when you want to develop some strategies, implementation, like recommendation after your project, it's when you read literature, it's so much diverse. There's no classification or I don't know how to say it in English, but une classification uniforme. I don't know.
So it's still, yeah. So I would, there are some taxonomies of implementation strategies. The most prominent one in the United States, coming out of the United States, is called the ERIC taxonomy, ERIC. I can't actually remember what it stands for. I have some issues. I love Byron Powell is the guy who leads that project. He's a great guy, wonderful man. But I have some issues with ERIC in that it mixes up the what and the how and the who of the strategy, and it doesn't organize them in a very useful one other than like alphabetically. It's like, but that is the most prominent taxonomy other than the behavior change technique taxonomy, which Daphne and I both talked about, but that's almost too elemental. It's almost too granular, and you're not sure how to combine them into a approach. So you're right. And I think this is, implementation science is a new field still, and we're trying to get the language right. And one of the signs of new scientific fields is that there's not a consensus on exactly how to do these things or call these things or describe these things. Science becomes normalized and moves along a lot faster if we can do those things, though. So it's important. I just don't have the answer for you yet because I don't think Eric is the best, maybe, but it has some real problems in my opinion. Even though I really like the people that made it.
Maybe one more question around managing fidelity issues and implementation.
Oh yeah, and we had that wonderful project talking about adaptation. Like, so adaptation and fidelity are it's one coin, opposite sides. And so just because we need to talk about definitions. So fidelity basically means did everything happen as I had hoped? Like when I went to go try to change things, did the thing that I hoped to implement get implemented? Did it get received or perceived in the way that I had hoped? Did they then make the changes that I would hope, and that lead to the outcomes that I would have hoped? So that's fidelity. And the issue of adaptation recognizes that, well, like in one clinic, obviously it's not going to be the exact same process as the next clinic. What adaptations are we going to need from clinic 1 to clinic 2 and so on? And how can we think through that in advance? If we recognize that, the world's complex and things are going to need some adaptation or flexibility, we pre-bake that in to the program theory, to the implementation plan, if you will. And ideally, we measure it, as was discussed. How we best think through fidelity versus adaptation for different situations and plan for it and measure it is like a really important frontier space of implementation science, especially in primary care, where like not only is every doctor different, but like every clinic is a bit different. It's a super rich space for you guys to do really important work.
Thank you. And so we're at time. Thank you, Noah, for joining us today and spending some time with us. And then thank you to all of the participants for being here. There's a short evaluation of the session when you close Zoom. And please join us for our next session on Tuesday, April 22nd with Dr. Catherine Donnelly. And she's going to be going over some practical tips on navigating proposal and grant writing in interdisciplinary teams.
Oh, and Catherine's lovely. You'll enjoy her.
All right. Then you should join us too. All right. See you. Bye.
Bye.